Hello, everybody, and welcome to this week's episode on Fit as a Fiddle. Today, our guest is Dr. Donald Tanenbaum, the renowned Dr. Donald Tanenbaum. Dr. Tanenbaum and I have known each other for probably around 5-ish years, maybe 6 years. And we have finally got him on this podcast. And I'm so excited and thrilled that he gets to share his expertise. Dr. Tanenbaum is a fellow graduate of Columbia University. He has been practicing for 40 plus years. He has been treating all sorts of things, but his specialty and focus is patients with TMDs, which are temporomandibular disorders, facial pain, headaches, sleep and related breathing disorders. He does a lot of continued training. He is the author of a book that I think I now read about 4 or 5 years ago. It's called Doctor, Why Does My Face Still Ache? And it's a great, great book. I recommend it to many of my patients who have TMDs. Very informative and is a gateway for you to really understand your own health. So I recommend everyone, if you're interested, please go and get that book online. Dr. Tanenbaum also lectures. He is the clinical assistant professor at the School of Dental Medicine at the State University of New York in Stony Brook. He is the director of the orofacial pain course. He is the sectional head of the division of orofacial pain, TMD, sleep medicine, and Northwell Health Department of Dental Medicine, and many more things that you can read in his bio. But all of that is to say, Dr. Tanenbaum knows his stuff. He's really good at what he does. He's really good with patients, patient outcomes, helping patients feel like they understand what's going on with themselves. Because I think a lot of when it comes to pain itself is really understanding the pain, where it's coming from, what's driving it. And he is literally the best person to explain that to you in ways that is just so much more informative and can really help you in your journey of overcoming that pain. So welcome to the show, Dr. Tanenbaum.
Oh, thank you for having me.
Yeah.
Wow.
So I'll let you go ahead and start off by just introducing yourself a little bit more in terms of what you actually do on a day-to-day basis. How does your practice look like? Where is it set up? And I guess like the most important things that you tend to see.
Okay, that's a good place to start. I guess from a background point of view, this is something that I've enjoyed doing for the last 40 years. Got a taste of it towards the midst of dental school and then created some opportunities to learn in the 1980s. Though there were some things happening in terms of continuing education, there really weren't any formal master's or fellowship programs. So those of us that are in my generation, self-trained, whether or not by having some mentors, spending time in other practitioners' offices, and then getting involved with other similar people and interests, and then creating academies and taking this thing from an early stage to where it is today. Um, the field that I'm involved with is now a specialty of dentistry. So 3 years ago, after probably a 40-year battle, the specialty of orofacial pain was born. The 12th specialty of dentistry never had been present before. But ultimately, a decision was made amongst those in political positions that it made sense to create a specialty. And as a result, over the last 3 years, you begin to see more and more university hospitals and universities begin to create post-grad programs. So you're going to see more individuals looking at orofacial pain as a career once leaving dental school, and they'll have places to go and train. And as long as there's a specialty, every dental student will know about it, whereas formerly, most dental students really didn't know much about the problems and certainly didn't know who to send to. But once a specialty is established, there's a much better opportunity for the dental community to understand that there are problems and now have people that are involved in solutions. That being said, the umbrella is orofacial pain, and underneath the umbrella are headaches, which could be tension headaches or migraines. You have temporomandibular problems, so problems related to jaw function. And in that context, these are orthopedic problems. So people that have problems with their jaw really have an orthopedic problem, and symptoms therefore have to do with the presence of pain, stiffness, range of motion, the presence of mechanical noises or instability. So really no different than knees and hips and ankles. And so the world of temporomandibular disorders and the diagnostic classifications are really set up now in a way where we can distinguish what is a muscle problem from a tendon problem, from a joint problem, which may be just unstable, to arthritic, or maybe due to Lyme disease or another medical disorder. And then we have, outside of that category of TMD, we have problems of nerve origin. So under the umbrella of orofacial pain, we see neuralgias, people that have nerve pain, which are very different than problems relating to the jaw. And those problems can be episodic, they can be continuous, they can be due to traumas, they can be due to medical illnesses, they can be due to chemotherapy, they can be due to so many things that leave muscles in a state of disarray, giving rise to pain that has high intensity in the absence of lots of findings. And then we see problems relating to extraction of wisdom teeth and placement of implants, and when nerve injuries occur by chance, not commonly, but they do in fact happen. And so you really have these three categories of problems. And then we see people that have lots of sleep-related disorders. So a patient who may have insomnia likely won't have a good pain threshold over time because they're not having sufficient sleep. And then during sleep, they may have some grinding or clenching of teeth, which overwork the jaw. Some of our patients have breathing disorders, which leave them struggling to get air. And so you see this big, broad canvas of patients that come to our office. Many of them are very common, very familiar, and very helpable. And then there are those that are less so. In the process of taking care of patients, not only do we spend a good deal of time on gathering information, but we also reach out to the community. So we have our clinical psychologists, physical therapists, sleep therapists, and others that are out there to provide assistance in patients that are struggling. And we certainly work with headache neurologists that only see headache, that can lend a hand with medications and things like that. So that's kind of an overview of what we do. Patients come into the office, and we spend most likely about an hour with patients on day one. My goal has always been to figure out who the patient is attached to symptoms, because after a while, all the symptoms sound the same. You have to figure out what the risk factors are that brought the patient to the necessity to seek care, make a diagnosis, and determine, which of those categories the pain fits or the malfunction of the jaw fits, and then begin to reach out into the office or to other practitioners for assistance in getting the patient better. So that's a big overview.
Yeah, that was very thorough. That's like taken straight out of a textbook almost. That was perfect. And hopefully that gives listeners just an understanding that, it's not just my jaw hurts, but there could be many reasons why it hurts or why your head hurts. And the mechanism of what's driving this pain is multifactorial. I think that's part of what you're also getting at. Like there's categories of these things and maybe some of them slightly overlap, but by diagnosing correctly, we can actually treat better. And as clinicians, that's the most important thing. Get a proper diagnosis, understand the patient, understand what's going on with them, what's all the biopsychosocial elements of this, and categorize it in a way that we can offer treatment appropriately. So on that note, I would like to first focus on the jaw pain that arises, or the, kind of TMDs that arise from the chronic bruxism, the chronic clenching and the grinding and the stress, which then drives headache. I guess my first part of the question is, how does those patients typically present? Like you said, you got to understand the patient. Like, what are some of the common denominators that you seem to tend to find in those patients? And what are some of the most effective solutions that you can offer in your practice or adjacent practices?
So a couple things. I think what should be apparent is that clenching and grinding of the teeth as separate entities don't necessarily do anything. There are millions of people in this world whose teeth are together at night, either in a static one position, or the lower jaw moving and creating sounds as the teeth clash. And some people even put them together during the day. And there's a whole percentage of that population that never has a symptom. They don't even know what they're doing. They never have an ache. They never have a pain. They deny they even do it. So the presence of a overuse of the jaw during the day and or a condition at nighttime that causes the teeth to be together more aggressively does not necessarily produce symptoms. However, if you think about the jaw, the lower jaw, as a movable entity, that's why it's an orthopedic problem. And if you try to understand why orthopedic problems occur, there are really only a couple of reasons. So you can always start with trauma. If you have an orthopedic system that sustains a trauma, you can appreciate tissue injury, pain, limited motion, instability. So you have trauma. But I would say that probably less than 5%, or maybe less than 10% of patients that we see have actually had a traumatic event other than biting on something that was unexpectedly harder than they thought. So they think they're biting onto a soft piece of candy during the holiday season. It's not soft, it's hard. And all of a sudden, when they bite down, they feel something pop in one of their jaw joints. They sustained an injury. Or somebody that has a eating disorder and has been vomiting excessively, thrusting the jaw forward for months on end, sustained sprains of their jaw. Somebody that had a general anesthetic procedure because of an appendix that was ready to rupture, and the putting of the tube down had to be done quickly. An injury occurs to the TM joint. Keeping the mouth open for a lengthy dental procedure or a lot of dental procedures over a short period of time. All of these things can create orthopedic injury due to a trauma. And we see those, but they don't dominate. Underlying medical illnesses. So if I were to look at another reason why people have problems in these jaw joints or temporomandibular joints, it's, for instance, they may have some general laxity. They have a systemic hypermobile condition. So we see many patients these days that have double jointedness, hypermobility, Ehlers-Danlos syndrome, where their connective tissue is just not healthy and stable. And as a result, neither of the jaw joints. We also see people that have a variety of rheumatologic conditions, things like psoriatic arthritis, gouty arthritis, rheumatoid arthritis, that create opportunities for breakdown within the hinges themselves. We see people with Lyme disease and other infectious disorders that affect the temporomandibular joints. And you can go on and on. So we see traumas and medical illnesses that can create havoc within this system and create pain and limited motion. But if you really want to know why we see most patients, I think it's a combination of three things. Overuse of the jaw, coupled with emotional tension, coupled with postural fatigue of the head and neck region. You put those three things together, and you can take a benign clencher and grinder that never had symptoms, and now you add a lot of life stresses, all of a sudden the same clenching and grinding becomes symptomatic. Or they all of a sudden have a good deal more postural fatigue of the head and neck. That can make the grinding and clenching that produce no symptoms now begin to produce symptoms. So we spend a good deal of time not only looking at overuse daytime behaviors, but what it is that took that daytime behavior and created a set of symptoms, because we know that millions of people with that same behavior don't have the problem. Mm-hmm. So why does one group of nail biters have no jaw problems and another group are miserable, right? Why does one group of patients who puts their teeth together during the day and they clench all day and have no problems where another group does? So, and in your world, the whole world of forward head posture and weak neck muscles, why do some people have no symptoms and other people are a mess? So I think our goal has been to listen to what people have to say, understand the history, understand the examination, and then at least postulate what we think are the risk factors that create a set of symptoms, and then try to understand what's been injured and what's not. And so that's really where we spend our time, because the diagnoses that are available, they're limited. And you can only have certain categories to pick from. You just have to figure out the why, and most importantly, who that patient is that's attached to symptoms. Uh, if you even look at something like grinding and clenching of teeth, you can have somebody that's done that for years, and now they're 16 years old, and they're in school, and they're not performing well. So what do they get? Adderall, Concerta. They get drugs to create focus. Or they're diagnosed with ADHD, and now they're on a stimulant like Strattera or Concerta or Ritalin, which puts people in a state of fight or flight all the time. So they may be performing better, but their system is in high drive. And all of a sudden, the old clenching and grinding, which never made a difference, now is symptomatic. And so those are the kind of things that I'm always looking for to see
Hmm.
what's changed. What took the simple jaw click and pop that never was symptomatic, just aware it was present, but no pain, no locking, and now it hurts and it locks. So why did that happen? Was it just a matter of years or something else added to the equation? And then, of course, um, if we have these problems, are they muscle in nature in the jaw? Are they muscle and the attachment tendons? So do we have a tendonitis? Do we have a joint that is unstable, but unstable with inflammation? Is the shock absorber slipping in and out of place, creating noise and locking? Those are the kind of things that we look at, and we try to figure out what the plan of action is to try to stabilize it and get people better um, within the time frame and means that they have.
I love that. Um, I think the one of the things that just stood out to me that you just described is that, taking a look at all of the factors, we need to make sure that we identify the different components and then target them individually. I think that's part of like what you were trying to say is it's not just the bruxism. So for example, it's not just get them a night guard. That's not going to solve their problem. It's more than that. And so we have to figure out the whole picture, figure out all of the
Yeah,
components.
I mean, certainly the night guard may be hugely critical to stop the impact or to diminish impact. The bite plate doesn't stop them from biting. It just lets them bite in a better neighborhood. The
Yeah.
question is, can you figure out the right neighborhood so that there's less injury? But then are there things going on during the day? I think what's really overlooked in the world of TMD is what's happening during the awake 16 hours. Everybody focuses on the sleeping 8, but usually the awake 16 are really where big time damage occurs. So, yes, you have to control nighttime injury, can't stop it necessarily, but mitigate it, and then figure out what to do during the day. Do we get people to breathe in a more mindful way? Do we get people to work on their core strength and their head position and postural stability? Do we get people to learn that it's not natural to keep their teeth together during the day, to change their behaviors? Some people think it's normal to live tooth to tooth, whereas the teeth should never touch. So if somebody exists in this world tooth to tooth, it's an acquired behavior. Well, why is it there? Why is it now creating symptoms? So those are the things we go after. And it's really a function of when you get patients, whether or not the tissue injury is early on, uh, mildly persistent or very persistent will determine whether treatment will help and in what type of time frame. So if I have somebody who just has a recent problem for a reason that I can identify, and we have a little bit of an acute sprain in the jaw joint for reasons that are understandable. Maybe somebody's went on a diet, now they're chewing a lot of gum they never did before, right? Or they change from a one diet to one that's a little bit more vegetarian in nature, or they stop cigarette smoking, or whatever they may do that's changed some patterns. If you can identify those things early on, you can address the injuries. But if the injuries are longstanding and chronic and persistent, and there's more inflammation and there's more secondary guarding and compensation, then the problems are more challenging. And that's where we typically always bring in physical therapists, because if in fact these things are orthopedic problems, why would this area not deserve physical therapy as much as a knee or a hip? So physical therapy we find to be critically important for education, to help people understand the relationship between all the body segments and how they connect and how dysfunction at one level can create dysfunction elsewhere. Um, Ergonomics relating to work, body sleep positions, uh, and even when they're working out, to begin to pay attention to what they're doing when they're working out. Are their teeth together? The body mechanics poor that are creating sprains and strains. But that's what these problems are. So when you start looking at true temporomandibular problems, it is really a broad categorization with a lot of information to be gathered to figure out the why, who the person is, what the risk factors are, and what does the patient have to do to participate to get better. These are never doctor fix me problems. This is always a participatory type of situation where I need help for somebody to get better. So if they're not paying attention to daytime behaviors, what am I going to do? If they're not changing their diet, they're not wearing the night guard, they're not doing the physical therapy or their exercises, they're not even taking medication for a month to quiet the inflammation. So if the patient doesn't understand the education and doesn't buy into the diagnosis and the why, very hard to get people better.
Yeah.
Just very hard.
Yeah, totally hear you. I see that all the time, and like even outside of TMDs, like anything related to pain for anyone, there's a lot of I'm going to go see somebody and they're going to fix me. I'm going to put my hands on them and then suddenly magically they're going to get better. And that is literally never the case. Literally never the case. And so I have to tell them usually when they ask me how long is it going to take to get better, I say it depends on what you're doing at home that I tell you to do. It just completely depends. If you do all the things very consistently, here's what the timeline could look like. And if you show up to my office and the next time just show up as if nothing has happened and nothing has changed, nothing is going to have changed. That's literally the answer.
Yeah, no, very true. So that's, I'm just trying to think what would be most helpful for your listeners to try to understand about jaw problems. Certainly, most people know that if you seemingly have a jaw problem, what's the first thing they get when they go to a dentist is a bite guard. And again, very important at times, but it may only be part of the problem. And then there's not just one type of night guard. There could be 4 or 5 variations of a theme based on the diagnosis. So if somebody just has a muscle problem, it may prompt us to deliver one type of dental appliance. If somebody has a certain amount of joint noise when they wake up, or their jaw is actually locked when they wake up, we need to make something to address that. If somebody describes a problem where their bite has changed, it may prompt the utilization of a different type of device. So all bite plates are not the same. Not every TMD problem requires a bite plate. And it has to be complemented by the daytime hours so that people go to bed with a jaw that's not been abused during the 16 hours, because the appliance can only do so much. So if the 16 hours unravels it, you can only hope for so much kind of progress. Then, of course, there are strategies during the day to change behaviors. That's key. So if we have a patient who has a lot of daytime behaviors, we need to change those so that that behavior doesn't overwork the jaw. So nail and cuticle biting, biting on pens and pencils, biting the cheeks of the lip, all those things overwork the jaw. They need to be addressed. If people have, some missing teeth that they've not addressed and are only chewing on one side of their mouth, that needs to be addressed. If people had a filling that fell out of place and as a result, there's an open contact between 2 back teeth and food is always getting caught between the teeth and they're fishing the food out with their tongue all day long, that needs to be addressed, because the more the tongue works, the jaw gets overworked, because the tongue is just a passenger of the jaw. So all of these little things may create a problem. If somebody has been increased on their stimulant medication, maybe that needs to be monitored by a conversation. If somebody is a crazy insomniac and never sleeps, we need to figure that out, because somebody that doesn't sleep doesn't heal. So those are all the key pieces. We turn to lots of injection therapies as well, just like any orthopedist or physical medicine rehab doc would. So we pick up needles a lot, not because they're curative, but they can sometimes begin to reverse the disease process and buy some time. So we do a lot of what we call trigger point therapy or dry needling, which basically you assault muscles that are in a state of tension, trying to coax them out of it, but trying to understand why they're in trouble in the first place. So whether it's the muscles of the upper neck, shoulders, face, and jaw, we do a lot of, we call it dry needling or trigger points, which is really done with the needle. The needle is a treatment, not the solution. We put a little bit of lidocaine in there for comfort, but the physical prodding of the needle, and it could be up in the face, the temples, the upper neck and shoulders. And then we may do that, 3 or 4 times with 3 or 4 week intervals, complemented by what? Changing behaviors, watching the diet, doing some physical therapy and exercises. If people have joint problems in the joint itself, that may be chronic inflammatory disease, or they have chronic tendinitis. We do something called prolotherapy, which is a kind of a resurrection of some old treatment out there about 50 or 60 years, where people put forward the concept that if you take something like dextrose, sugar, along with some lidocaine, and you introduce the dextrose into a tendon that was chronically inflamed, the dextrose would actually create new inflammation. Now, that doesn't seem to make sense, but sometimes when you create new inflammation in an old site, it brings the body's attention to the problem, and all that is necessary for healing. So we do a fair amount of prolotherapy in insertion sites, tendons, ligaments, joint capsules. There's always steroid. Steroid is not a bad thing when used appropriately. We certainly put some steroid in chronic tendinitis. We use it in TM joints that are grossly inflamed or sprained or arthritic. You have a whole new world emerging of regenerative medicine now, where you can begin to think about spinning down somebody's blood and taking certain fractions of that blood and putting it into a temporomandibular joint. Still not the greatest science, but it's something we're exploring, we're beginning to use. The jury's not out. But if every other joint system is being treated that way, how could we not be doing it? And so we've kind of leaned into that world. And then, of course, everybody has the question about Botox. Shouldn't everybody get Botox for TMD? Again, Botox, does a couple things. It reduces the ability of a muscle to contract aggressively. So certainly a clencher and a grinder may think that Botox is the one and only appropriate therapy, and sometimes it is. Sometimes we can put some Botox in somebody's jaw muscles and diminish the force of contracture for 2 or 3 months, maybe break them out of cycle. They still need to work on changing the behavior, but sometimes it breaks the cycle. Botox also works beyond reducing muscle contraction by quieting nerve pain activity in muscles. So the reason why Botox is used for migraines is because it actually diminishes the release of certain pain-producing neurochemicals. We have found that there's a proportion of our jaw pain patients that the Botox really is working more on the nerve mechanisms, not the muscle. And you find that out because the people who have the muscle problem, I put some Botox in 2 times, maybe 3, with 3 to 6 month intervals. They get better and they disappear because we've shut the muscle down. They've changed the behavior. The other factors have been addressed, and the muscles had to just get healthy. Those that keep coming back to me every 3 or 4 months, tells me that though they got great benefit, as soon as the Botox wore off, they needed it again. It had to be more than a muscle problem. It's probably a neuropathic problem in the muscle and not the muscle itself. So we're seeing a bit of a variation on that theme as well. And certainly we are using more Botox now in some of the upper neck muscles to deal with cervical dystonia and things like that. So not uncommon now to start putting some Botox into the upper trapezius muscles and where they at the hairline. And we use that often for people with jaw problems because the neck muscles are the primary recruiters of the jaw muscles into a state of tension. So we're doing a bunch of that as well. Clearly, all this takes time to figure out. And so there's a big canvas of treatments. Just got to figure out, where they fit. And again, going back to, who is the person attached to this? Why are they in trouble? Can we figure out the risk factors? And are they capable of helping us reduce the risk factors? They may not be able to. And then you kind of struggle along.
Yeah.
Yeah.
I love that. So you talked about the night plates, the bite plates, obviously all the education, the changing the daytime behavior. I like that term. I'm going to start using that with my patients because I don't think I say it that way, but I think it's important for them to understand that, yes, they are awake most of the time.
We call it physical self-regulation. We tell people to um, just begin to get a glimpse of what you do during the day. Now, whether or
Hmm.
not it's by downloading an app that provides a gentle chime or vibration every 5, 10 minutes. So if there are patients who admittedly are tooth to tooth during the day, or always biting their nails or cuticles, or always have their arms crossed, or their shoulders up, or hold their breath, you need something to prompt their attention. And
Yep.
so the prompter then gives them a series of things to do. So we've added, for most all patients, there's a breathing component to care now, where we use a reminder to prompt some breathing to try to reduce fight or flight and increase rest and digest and get the vagus nerve and other parts of the nervous system to that are designed to cause more relaxation to be more engaged. And so that's really a big part of the day for many patients, just becoming aware of what they do. Um, and it's remarkable. Sometimes
Yep.
just changing a behavior or a
Hmm.
posture or a repetitive movement, what can happen after 4 to 6 weeks where people come back and they're feeling better because they've just become more educated, more aware, and more participatory. And yeah, they're
Yeah.
often surprised in how much less they hurt.
Yeah, I can think of two patients just very recently where I was able to observe, but because I don't do as many home visits now, I ask patients to have somebody take a picture of them when they're in their natural working environment, like a couple of minutes into them just settling into their space, to take pictures from the back, the side, the front, so I can see how they are. And it was just so obvious. Somebody
Hmm.
had their monitor on the right side, at like a second monitor on the right side, and their main monitor in their center. So what are they doing most of the time is they're shrugging up their shoulder and putting it onto a armrest that's way too high for them. And then they're basically just hunching and leaning forward into their left arm so they can turn around and work on their right screen, which tends to be, something that they look at like every few seconds almost.
Yes.
And so I saw this and I was like, we just like, what are you doing? We got to change the monitor. Like, can we put it so they're 50-50 and then you're going back and forth? And this is a way healthier, more symmetric movement pattern that's less into a range of motion in your cervical spine, especially. And there's just so many things we can do. And then the same thing, there was another patient who she didn't have a home office. She admittedly said, I sit on the couch and I do my work. And I said, okay, show me how you do it. And she puts her computer onto the rest of the couch that she sits on, and just shrugs her body over it and kind of types in an asymmetrical way for like hours and hours and hours. And so you just look at these big, stark asymmetries, and then you can look orthopedically because they're usually, you just do a quick range of motion screen and you can see that there's stuff in their hip that's off, and the way that they're side bending to the right versus their left, and their lumbar spine looks different. And all of this just accumulates into this chronic state of overuse just because of simple, pure postural dysfunction because of asymmetrical living habits, working habits, sleeping habits, all that kind of stuff. And so I think I love the way that you said, the words that you use, and the daytime habits and all the things that they need to look at, because on a global level, everything is connected. And so if you can just make those changes initially, that's probably the most important thing. Like, forget even coming to physical therapy and getting any kind of exercise done. Because the way I always say is, if you do 3 sets of 10 of this exercise I told you, and then the whole rest of the day you go and live in that same asymmetrical, weird posture, it doesn't matter. It doesn't net out to make any sense, and you might as well have not done it. You hold a stretch, I told you to do it 3 times a day for 1 minute. It doesn't matter if 23 hours you're sitting in a particular way or working and moving in a particular way, you know?
Oh, very true. Um, Muscle systems, orthopedic systems easily get exhausted. They become unstable. They become symptomatic, and then they don't function well. And if they're
Mhm.
continually insulted, you don't heal. If you don't heal, you don't feel better. So, in this world of TMD problems, it's all about tissue healing. And the question is, what's injured? How badly? Is it reversible? And what's going to take it to heal? And then how do you maintain that? Uh, and, look, none of us know for sure where people go long term. We get lots of people better. We discharge a lot of people, as you do. I'd love to know where they are a year and a half later, whether or not they've held on. to
Mm-hmm.
all the things that they've modified and changed. But sometimes long-term follow-up is really hard uh,
Mm-hmm.
to really figure out the why.
But
What
it
else?
sounds like if you discharge them, they're doing better. At least that's what I hope and pray. Every once in a while, they'll come back and be like, I think I need a tune-up. You need to remind me of everything we talked
No, there's
about
no question.
3 years later.
We have a lot of patients that come back, whether or not it's for us to check their dental appliance that we've given them to deal with sleep bruxism and clenching and grinding, and they feel that if they come back twice a year for us to resurface it, rebalance it, it makes a big deal. Now, we also may reinforce some of the other concepts that we've shared with them. There's some people that come back to us every 2 to 3 months for a little bit of dry needling of their neck and jaw muscles because they feel if we do that, they don't take Advil, Aleve, and Tylenol. It just helps enough. They don't have to do that. So there are a lot of scenarios like that. Sometimes I see people that come, they've seen me, once a year for Botox for 3 years in a row. Once a year, just when they feel like they may be getting over the edge. That's hardly excessive use of it. It's probably appropriate for that individual, while others may get it once or twice, have a satisfactory result, and move on. Uh, and the same thing with physical therapy, right? Need a tune-up, need a reminder about ergonomics, need to go back to those exercises or to learn how to do them properly. Uh, all important. All
Yeah.
important.
So I'm going to ask you a question that I think it's a tough question for me to always answer. And I'm curious to hear what your answer is when patients ask you this. So when it comes to lifestyle changes, I get this question all the time from head to toe. If I'm treating somebody with chronic back pain or chronic this pain or chronic that pain, they're like, do I need to stop doing X activity that's been making it worse? Right. And so especially if that thing is either their lifestyle, their livelihood, or their passion, it can be tricky. But when it comes to the TMJ specifically, I get questions like, so can I never eat into a hard bagel or a big burger ever again? Because I know we've been doing PT for a while and it gets so much better. And, we start to grade our eating into a small, slightly soft carrot and we start grading it. And then I want to go eat that burger. So I just go into it and it gets me back into a bit of a regression. And so they come back after that happens like 1 or 2 times. They're like, so does this mean I just can't eat it anymore? What is your answer to that? I'm curious to learn from you. How do you
No,
answer?
I look at it like any orthopedic problem. If somebody's had a bad sprain of their knee, right? One would think that a full healing has occurred through time, medication, rest, physical therapy, exercises. If healing has occurred and the repair has occurred, one would think that they should be able to go back to tennis, et cetera, right?
Mm-hmm.
That's kind of how I look at this. I look at this as an orthopedic problem. I find that most people that really have pain with eating is because they have a joint problem. They don't have a muscle problem. Muscle problems don't really kick off unless you have something in there like beef jerky, where you really got to plow to go through it. But the patient who really has pain with chewing, I typically think it's really more of an intracapsular problem in the joint, which means in order for them to be able to get back to what they want to eat, that inflammatory process, that ligamentous instability really has to be managed properly. And so there may be care avenues that have not yet been pursued, which has not fully addressed the injury, which has left them fragile and susceptible to eating related symptoms. Because people say to me, am I ever going to eat a bagel again? Well,
Mm-hmm.
there's some treacherous foods out there like bagels. Well, maybe not. Maybe a fresh one that's steaming out of the oven, but a 2-day-old bagel? I don't think so. Or dried fruits or dried meats or baguette breads from France. There are certain things that really require a lot of coordination and stability and health. So if you have a joint that has really lingered and is much better on a daily basis, I still tell people to really be cautious with that. Um, and then they may need some more direct therapy into that joint. So if the joint's not getting better, there may be a different type of dental appliance they need. Maybe they need an injection into the joint, right? Maybe they need to change their behaviors a little bit more. Um, don't yawn so much. So yawning is an interesting thing. We really focus. Yawning is really treacherous for people with joint problems.
Mm.
Um, so the two worst places for your jaw are teeth together and widest apart. Together, you're just creating basically a fist in your face, which can't be a good thing. And opening too wide, you're putting those ligaments at risk. They may already be in trouble. So we spend a lot of time having people at least try to reduce the extension. So tongue to palate is common. If you stick your tongue to the roof of your mouth, you leave it up there, really can't open wide. That's really important. Yeah, so wide mouth opening is an issue. But I believe that there needs to be some degree of caution with eating. And if so, it's probably because a joint injury has lingered to some extent.
Yeah.
There's this whole other conversation, which depends on how old and how gray you are, determines how easy it is to have. We still see 70% of women in our practice with TMD problems. So the whole concept of intimacy is not nothing.
Mm.
And it's sometimes hard to talk about, particularly if an 18-year-old comes with her mother or whatever it may be, but it's real stuff. So
Mm-hmm.
there's no question that issues of intimacy can be very injurious to a TM joint.
Mm-hmm.
And once injured, how does it get better? Got to stop new injury.
Mm-hmm.
So you have all those issues too that need to be discussed at times, or at least framed in a way that's not embarrassing, but nonetheless discussed, because no question, it's a risk factor.
Mm-hmm.
And so all these things may determine whether or not somebody can get back to eating, right?
Yeah, absolutely.
Yeah.
Well, I'm also a pelvic floor physical therapist, so all this is right under my lane of fire for
Right under
people.
your line of fire.
Yes, and I
Yeah.
always say no information is too much, because everything you tell me actually is only going to help me. Even if you think it's weird or you think
Yeah.
it's crazy, it's not.
I mean,
We're here to help you.
if you look at our population of patients, yeah, they have TMD and they got gastrointestinal distress and they got pelvic floor and they got neck problems, they got sleep issues. They have so many tangential comorbidities, sometimes
Hmm.
challenging to get them all under control.
Yeah.
The simple ones are the simple ones.
Yeah, I actually always find that a patient that comes to me with pelvic floor dysfunction or TMJ, vice versa, when I discuss to them about the other joint, often they will have an issue there that they didn't even know could get addressed. And
Yep.
they'll realize that sometimes there is something to be said about over clenching, over guarding, high, intensity of muscle activation, that the inlet and the outlet kind of both contribute to in some capacity. And so often I treat these people with my first exercise, like yours, always being diaphragmatic breathing. How do we do a top-down approach of, like, where do you get your neck and head into a better position? How do you relax your jaw? How do you take a diaphragmatic belly breath in? How do you relax your pelvic floor muscles? And how do we coordinate that whole thing together so that we can address all components from top to bottom in a healthy way? Because I find that they're sometimes very related, and they can come in tandem together.
No question about it. Yeah, I'm sure that people's neural systems and regulatory systems are just thrown off, and they lead to physical related ailments and symptoms.
Yeah,
That's what
absolutely.
these things are.
I know. Well, Dr. Tanenbaum, I want you to take an opportunity to say anything else that you'd like to for our audience. Anything else that you feel like is the biggest takeaway or the most important things that you may tell any patient that walks through the door, like, over and over and over again. I know you've said quite a few of them, but is there anything that you want to add to that as we close up here today?
You know, I think the key for our practice is to listen, um, validate. I think validation is huge, particularly if people have been searching for answers and haven't found any. Uh, so we listen, we validate, we give a diagnosis that's understandable. We try to discuss the risk factors that are present that may have driven it, and let's try to address the ones that are addressable. Give some hope and optimism. And we always add a participatory piece so that there's a level of involvement. Sometimes we set expectations early on, so whether or not we think we can help somebody all the way, or 70%, 40% for some people with chronic persistent problems. That's enough. So I think you need to set those expectations early on. But for the most part, particularly if we're focusing on this TMD world, uh, these are common, familiar, helpable problems. Many of them have pretty clear-cut, straightforward solutions. Some require a little bit more. Every now and then you have a surgical problem, as with any other joint system, and that's not a bad thing. It's sometimes a necessary thing. But certainly, I think getting patients really understand what they have, why they have it, and what it means going forward is probably the most important thing. Yeah.
Yeah, I love that. So where do people find your practice and how do they get in touch with you if they want to learn more?
Well, we have we have more than two offices now, so we kind of rebranded this whole thing 2 years ago. So it's now called New York TMJ and Orofacial Pain. So took it a little bit out of my name. And we have a bunch of young docs in there now. So if you look at my city office, we have two new docs over the last year and a half. John Dinan, who's a graduate of a training program in the Air Force and Navy. He's actually an Air Force graduate, but did a training program in the Navy. He's in our practice in the city, and Amy Werfel, young lady that's been with us about 16 months now. And she is seeing these patients and a lot of competence and caring ability. And then we have a practice up in White Plains. So Steve Syrup, Steve's been in New York forever as well, 40 years with me. He's going to be finishing up in New York by the end of March and just seeing patients in White Plains 2 days a week. We have my office out in Hauppauge, which is out in Long Island. And there's a new office in Woodbury where I brought a young fellow in from UCLA who's trained in a master's program at UCLA in orofacial pain, Dr. Fayak. He's with me 4 days a week. And then John Dinan is also in a Ridgefield, New Jersey office that we just opened. So a lot more accessibility, lots of youth and energy.
I love that.
And it allows me to sit home and get better from my knee surgery for 6 weeks.
Well, I'm so happy that you've found that, and I've met Dr. Warfel, and she's amazing. So I'm very glad that you have a team of these amazing people. And for listeners, you can literally Google Dr. Tanenbaum, Dr. Donald Tanenbaum. You'll find all this information on his website too, which I'll put down in the show notes. And like I mentioned, he has a book that I think people should definitely take a look at. It's called Doctor, Why Does My Face Still Ache? And he covers some of these things and more in detail. So I hope that this podcast has inspired you guys. If you are coming here because you have some level of orofacial pain in some capacity, I hope that you are able to learn a little bit about that and able to seek care and treatment, because you're not alone. There are literally people who specialize in this world and do a really good job at it. So I hope you get the care that you need. And if you want more information, you can definitely reach out to either of us so we can point you in the right direction and to the right resources. So Dr. Tanenbaum, thank you so much for your time today and for making it happen, because I know we've been at it for a long time to do this.
Yeah.
But it worked out, and I'm sorry it's at the expense of your knee surgery, but here we are.
Thank you so much, and look forward to chatting soon.